This conference will now be recorded.
Hello.
Hello, yes, we can hear you, Prerna.
Preeti.
Uh,
Yeah. You can see my PPT also, na?
yes, we can see you and
Okay.
your PPT. I'll make a group call and come. Huh? Sometimes I just require,
Yeah.
yeah, okay. And those who have already joined the session, please don't pick up the call. Yeah. I suppose we can start. Others will join later. Yeah.
Okay. Okay. Yeah. Uh, whoever is attending this lecture, can you please give me a confirmation that you're able to see the screen, the PPTs and all? Just
Yes, ma'am.
unmute yourself and yeah. Okay. Rest.
Yes, ma'am.
Okay. Rest, all of you are there. Aditi, Akanksha.
Yes, ma'am. Akanksha.
Yeah. So I'll start. Suvarna is there. Hello. Suvarna.
Yes, ma'am.
Okay. I'll start then. Yeah. So I am Dr. Prerna Gaikwad, and today's lecture is all about the physiological changes in mother during pregnancy. Okay. 1 second. Yeah. So we all know that the normal average duration of pregnancy is 280 days, that is 40 weeks, calculated from the first day of the last menstrual period, or 256 to 270 days from the time of ovulation. So during pregnancy, whatever increased demands are there, they're all met by certain adaptive changes in the mother's body. Almost all the systems are taking part. Okay. So today we are going to see the changes which occur in genital organs, then weight gain, hematological changes, cardiovascular changes, respiratory changes, then urinary system, gastrointestinal system changes, metabolic changes, endocrinal system changes, and changes in the skin, as well as psychological changes. So if you have any doubt, you can stop me at any moment and ask me questions. If I'm going too fast, let me know. Okay. Am I audible?
Yes, ma'am. Yes.
Okay. Yeah. So first is changes in the genital organs. We all know that obviously uterus has to take part as a growing fetus is there. So uterus undergoes gross and histological changes. Then there is changes in the ovaries, cervix, fallopian tubes, and mammary glands. So first we'll talk about the uterus. Gross changes, we all know that obviously the weight increases as the fetus grows. The weight increases from 30 to 50 grams to 1000 to 1200 grams at full term. The length increases from 7.5 centimeters to 35 centimeters. The thickness of the wall of the uterus decreases from 1.25 centimeters to 5 millimeters. The advantage is that as the thickness of the wall decreases, the fetal movements can be easily palpated. When volume increases from few ml to 5 to 7 liters, the shape changes from pyriform to globular. So in all, the weight increases, the length increases, the volume increases, the thickness of the wall of the uterus decreases, and the shape changes from pyriform to globular. Then there are histological changes. We all know that there are three layers. There is perimetrium, endometrium, and myometrium. So endometrium shows testicular changes, myometrial changes. So the muscle layer in the uterus undergoes some changes. So there is increase in the number, the diameter, the length of the muscle increases, and they form an interlacing network in the form of 8 around the blood vessels. This characteristic helps in controlling the blood loss during separation of placenta. Okay, so these muscle fibers will prevent the excessive blood loss. Okay, all these changes in the uterus occurs in the first and the second trimester under the influence of estrogen. Ovarian changes. So we all know that the follicle undergoes many changes in the development, right from primordial follicle to the primary follicle, secondary follicle. You can see in the diagram. Ultimately, it forms Graafian follicle. Then there is ovulation, and the surrounding layer, that is corpus luteum. Okay, so this corpus luteum enlarges during the initial 12 to 16 weeks of pregnancy, and later on it degenerates when the placenta takes over the function because of the decrease in HCG. So the follicular changes and ovulation does not occur during pregnancy. Furthermore, follicular changes and ovulation do not occur. Can anyone tell me what is the reason for this? Anyone? Akanksha, Suvarna.
Separation because of high estrogen and with HCG.
Right. Actually, throughout the pregnancy, there is increase in the level of estrogen and progesterone. So, by negative feedback, they'll decrease the levels of FSH and LH. Both these hormones are necessary for the development of follicle and ovulation. So, there's suppression of FSH and LH, because of which the follicular changes and ovulation does not occur. Just a second. I think there's some problem with the slide. Yeah. So cervix undergoes changes too. So endocervix gets hypertrophied. Cervical glands increase in size and secretions form a plug that closes the cervical canal. Tough cervix becomes soft. Because of the increase in the size of uterus, because of the growing fetus, the fallopian tubes are pushed upwards. There is hyperplasia of epithelial cells and blood supply to the fallopian tubes also increase. We all know that the mammary glands undergo changes. That is, there is hyperplasia of the ductal and alveolar tissue. Areola becomes pigmented, and the sebaceous glands become more prominent. The nipples enlarge and become pigmented. So there is increase in the size of the breast. There is more and more of pigmentation. Obvious function is lactation and nourishment of the newborn. Coming to weight gain, the most characteristic feature which we observe in the patient throughout the pregnancy. So the total weight gain is of 10 to 12 kgs. Fetus contributes 3 kg. Placenta and amniotic fluid contributes to 1.5 kg. Uterus and breast enlargement almost 1 kg. There is increase in blood volume and interstitial fluid almost 1.5 kg, and fat deposition is 3.5 to 4 kg. So we have to constantly keep the weight gain in check. If there is excessive weight gain, what can be the possibility? Too much of weight gain during
PI,
pregnancy. Yeah,
pregnancy hypertension.
right. Okay. And if there is decrease in weight gain, what does it signify?
Malnutrition is deficient,
Yeah,
IUGR.
fetal growth retardation. Correct. So initial phases, initial first trimester of pregnancy, there might be slightly weight loss because of excessive vomiting. Okay. But the second and third trimester, we have to keep the weight gain in check. Then there are certain hematological changes, that is blood volume, hematological indices, changes in plasma proteins, the number of leukocytes, platelets, and coagulation factors. First, we'll discuss about the blood volume. So blood volume increases by 30% from 12th week of pregnancy till delivery to increase the blood supply. So obviously, when the fetus is growing, we need more and more blood supply to certain organs. That is, first is uterus. Okay, there should be more and more growth of uterus to accommodate the fetus which is growing. Then increased blood supply to skin to dissipate the heat which is generated in the body, and kidneys for excretion of extra waste products. So all these three things need more and more of blood supply. What is physiological anemia of pregnancy? There is increase in blood volume. Then why this anemia is occurring in pregnancy, and why is it called as physiological anemia?
There's an
Anyone?
hemodilution. The plasma volume is more than the RBC volume. So there is a
Correct.
relative anemia as such.
Yeah. So more of plasma volume, there's increase more and more retention of sodium and water. So plasma is increasing as compared to the RBC count. That shows a picture of hemodilution. That's why it is called as physiological anemia of pregnancy. So it appears that the RBC count is decreased. Actually, in the figure you can see as compared to the normal, the plasma volume is increased almost 40%. RBC count is increased by 50 to 25%. But because of hemodilution, it appears to be that RBC count and hemoglobin concentration is decreased. So shows a picture of anemia. Packed cell volume decreases. Obviously, the cellular component, if it is decreased as compared to the plasma, the packed cell volume appears to be decreased. Then erythrocyte sedimentation rate increases. What is ESR? Can anyone recollect from first year what is ESR? Erythrocyte sedimentation rate. So if you take a sample of blood, you put it in the
It is the
test
rate
tube
at
and keep
which
it for
the RBCs settle down, the sedimentation
correct.
time.
At the end of 1 hour, if you observe that the RBCs are collecting at the bottom, the cellular components are collecting. So RBC compromise the maximum count of cellular component. If they settle down and whatever portion is cell-free portion is remaining at the end of 1 hour, that is called as the rate at which they're settling down is called as erythrocyte sedimentation rate. So if the cellular component is less as compared to the plasma volume, they'll settle down faster as compared to the normal person. So ESR is increased. Obviously, the reticulocyte increases. The body senses that there is decrease in RBC count, decrease in hemoglobin. So they to compensate for that, they try to increase the rate of erythropoiesis, and reticulocytes are one of the components. The last stages or immature RBCs, they also increase. Okay. In the diagram given below, you can see the plasma volume is at the higher level. So it is increased as compared to that of red cell mass. Okay. That gives the picture of hemodilution or physiological anemia. Everyone clear at this point? So very easy to remember, right?
Yes.
Hemodilution. Yeah. So plasma proteins, they decrease from 7.5 to 6 gram per cent due to hemodilution. Fibrinogen increases, very important point. Fibrinogen is increasing from 200 to 300 to 300 to 400 milligram per deciliter. Serum albumin is decreased and globulins increase. Normally, albumin concentration is more as compared to the globulins. So in pregnancy, the picture is reversed. Okay, what you need to remember is plasma proteins is decreased because of hemodilution. Fibrinogen is increased, causing a hypercoagulable state, and the albumin to globulin ratio is reversed. Okay. Coming to leukocytes, the total leukocyte count increases and may reach up to 20,000 per cubic millimeter. Polymorphonuclear cells predominantly are increased. Regarding the platelets, there might be slight decrease in the platelet count. Most important thing, that is coagulation factors. So it is a hypercoagulable state. We all know that it is very important throughout the pregnancy and especially during the last stage, during the time of labor. So hypercoagulable state is due to increase in the coagulation factors like fibrinogen and factors 7, 8, 9 and 10. This hypercoagulability plays a significant role of hemostasis in controlling the blood loss at the time of separation of placenta during delivery. Okay. Coming to cardiovascular changes. So what we are going to discuss today is position of heart rate, cardiac output, blood pressure, blood flow and venous pressure. So first is position of heart. So heart is displaced laterally upwards and slightly rotated on its long axis. Obviously, if the apex of the heart is shifted laterally, the ECG will show left axis deviation. Okay. Heart rate, it increases by 10 to 12 beats per minute. Cardiac output increases from 5 liters per minute to 7 liters per minute at 20 weeks of gestation. The cardiac output increases due to increase in stroke volume and heart rate. We all know that cardiac output is calculated by stroke volume into heart rate. So if there is increase in the stroke volume, there is increase in the blood volume and increase in the heart rate, ultimately it will lead to increase in cardiac output. So all these changes are all aiming to increase the blood supply, to increase the blood flow to the different organs also for the growing fetus. Blood pressure. So systolic blood pressure may fall a little or it might show absolutely no change. Diastolic blood pressure decreases by 16 to 20 weeks. Then it starts rising and comes back to normal. So whatever changes are there in diastolic blood pressure, they are because of vasodilatation, which is occurring due to the vasodilatory factors, that is kinins, the endothelium derived releasing factor, and nitric oxide, which cause a fall in diastolic blood pressure. Blood flow to the skin, uterus, and kidney increases. We have already discussed about that all these three systems need increased blood flow to meet the demands. Venous pressure. So this growing uterus, gravid uterus exerts pressure on the pelvic, abdominal, and femoral waves, resulting in edema of feet. So this is very commonly observed features, that is edema or swelling of the feet. Increased abdominal pressure can predispose to varicose veins, piles, and peripheral venous thrombosis. So here in this diagram, you can see different changes which we have already discussed. So there is comparative increase in the heart rate, Then you can see the changes in the Q wave in lead 3, then reduction in the PR interval, and most importantly, left axis deviation. So normally it points out to 45 degrees, but in this case, in pregnancy, it might show left axis deviation because of the growing fetus. That is, change in the position of the heart because of the increase in the size of uterus. Everyone clear? What all the cardiovascular changes we have seen? Okay. Anyone is having any doubt regarding this?
Ma'am, regarding the blood
Yeah.
pressure, the
Yeah.
systolic may rise in pregnancy.
It might rise, but slightly. That's why you need to differentiate whether it is any abnormality. But normally, the body tries to correct the changes. Okay. So systolic might not show that much of change, but diastolic, yes, it will fall because of
Yes.
the vasodilatation. Yeah. So
So it is
significant
not
changes will
common
also
like
be
this
seen.
is
Yeah,
the
yeah, yeah.
systolic and
So
that's not common like.
yeah. So systolic blood pressure changes won't be expected that much, but diastolic blood pressure has to fall a little bit as compared. Okay.
Okay.
So coming to respiratory changes then, obviously if we are discussing any system, first we go to anatomical changes, then hyperventilation, ventilatory functions, gas exchange and O2 consumption. So first anatomical changes, again elevation of diaphragm by the enlarged uterus. So there is increase in the transverse diameter of the thoracic cage and the subcostal angle. In this diagram you can see there is increase in the transverse diameter and the subcostal angle is also increasing. Okay, so these changes increase the airflow across the bronchial tree. Okay. Hyperventilation, one of the most important features of respiratory system changes. So these high levels of progesterone increase the sensitivity of respiratory neurons to CO2, resulting in hyperventilation. We know that respiratory center, it is very sensitive, and this progesterone is increasing the sensitivity of respiratory neurons to CO2. Okay, so hyperventilation will lead to decrease in the PCO2 value. Okay, more and more CO2 is expelled out and there is decrease in the PCO2. Maternal blood PCO2 will decrease by 10 to 15%. This factor or this feature is very, very important. Can anyone tell me how does it play a significant role? Why the maternal blood PCO2 has to decrease? Why hyperventilation is occurring? How this feature is going to help?
There's more demand for the oxygen.
Yeah, but if the PCO2 is decreasing because of hyperventilation, what will happen? How it is going to help the fetus?
The erythropoietin will be secreted more for the hemoglobin
No.
synthesis or something like that.
Anyone else? You're trying good, Suvarna, but there's one more feature that is important. So obviously, there's increase in O2 demand, increase in the production of CO2, more and more respiratory alkalosis, right? This respiratory alkalosis plays an important role in acid-base balance. It helps in the fetus in accepting more and more of O2. So we'll be discussing it in detail. We could just get in the next slide. We'll be discussing that. But this respiratory alkalosis plays a very, very important role. Can you recollect the O2 hemoglobin dissociation curve, what we have learned in first year, right? O2 hemoglobin dissociation curve. So there are three factors which regulate this curve, that is pH, changes in the pH, change in the temperature, changes in the level of 2,3-DPG. All these factors control the loading and unloading of O2 to hemoglobin. Okay. Yeah. So when we discussed about different respiratory system changes, if you can recollect, this is the diagram of showing different volumes and capacities. Okay. So normally you can see The tidal volume as compared to the normal person in pregnancy, it is increased by 40%. And functional residual capacity, the residual volume is decreased as compared to normal. So the total lung capacity is also decreased. Okay. The vital capacity remains unchanged. The drastic change in volume is that of tidal volume, which is increased by 40%, and functional residual capacity is decreased by 20%. By just taking a look at the graph, you can notice the changes which are occurring in pregnancy as compared to the normal person. Gas exchange. There is increased gaseous exchange due to increase in the pulmonary blood flow. We have already discussed there is more and more O2 demand, there is more and more increase in the plasma volume, increase in the blood flow. Okay, so more and more increase in pulmonary blood flow, more amount of blood is flowing through the lungs, more and more amount of gaseous exchange is occurring, O2 and CO2 exchange. Then O2 consumption increases by 15%. Okay, clear about the respiratory system changes? Anyone having any doubts? Hello? Yeah. Why others are not interacting? Aditi, Akanksha. Suvarna, you there?
Yes, ma'am.
Yeah. Okay. So we'll quickly go to the next slide. Yeah. Coming to urinary system changes. So there are different heads, that is renal blood flow, effective renal plasma flow, glomerular filtration rate, then renal tubular absorptive capacity, clearance rate, glycosuria, proteinuria, water balance, and acid base balance. Talking about renal blood flow, it increases due to increase in cardiac output and vasodilatation. We have already learned about this, that there is increase in the cardiac output, increase in the blood flow to the urinary system. That is, the renals also observe increase in blood flow, okay, because of increase in cardiac output and vasodilatation. Effective renal plasma flow, it increases by 60%. Glomerular filtration rate. If you recollect the diagram of Bowman's capsule and glomerulus, renal tubules, and urinary system, we know that there are three steps which are occurring. First is the filtration, that is at the glomerulus. So if there is increased blood flow, it is directly GFR is directly related to the increased renal blood flow. So if the renal blood flow increasing, obviously the glomerular filtration rate will also increase, and increases by 50% due to increase in renal blood flow and solute load. Renal tubular absorptive capacity, the second stage is of tubular reabsorption. So more and more increase in blood flow, more of GFR, more of renal tubular absorptive capacity. It increases especially for sodium and chloride by 50% due to high levels of steroid from placenta and adrenal cortex. We all know which are the hormones which increase the sodium and chloride retention, sodium and water retention, right? So the renal tubular absorptive capacity for sodium and chloride also increases. Clearance rate. So the clearance rate increases for creatinine and urea. So if you observe in pregnancy, the plasma levels of creatinine and urea is decreased because more and more of these substances are getting cleared from the renal tubules. In this diagram, you can see there is increased blood flow to the kidneys, obviously leading to increased GFR, increased urinary output, leading to increased frequency of urination. When there is increase in the size of calyces, renal pelvis might lead to hydronephrosis, light hydronephrosis, increased size of ureters, that is hydroureter, and Under the influence of progesterone, there is hypomotility of ureters, might also lead to frequent urinary tract infections. Okay, so these are the changes what we observed in kidney or urinary system. Then there is something called as glycosuria and proteinuria. Normally, glucose or proteins are not found in urine. So presence of these, right? Presence. Hello? Yeah, anyone's having doubt? So normally glucose and proteins are not found in the urine. There is presence of glucose and protein in pregnancy. Okay. Coming to water balance, excess water retained due to decreased protein concentration and decreased colloidal osmotic pressure and more of sodium retention. We know that because of the release of steroidal hormones, there is more and more of sodium and water retention. Acid base balance, we have just discussed it. That is hyperventilation in pregnancy resulting in respiratory alkalosis. Correct? So decrease in the PCO2 level is causing left side shift of O2 hemoglobin dissociation curve. So maternal blood is accepting more and more of oxygen, but when it reaches the placenta, which acts as fetal lungs, there is more, you know that whenever there is change or difference in the partial pressure of any component, that is, for example, if CO2, so partial pressure of CO2 in fetal blood is more as compared to that of PCO2 in maternal blood, there will be more acceptance of CO2 from the fetus to the maternal side. So this difference in the partial pressure will cause more and more exchange of CO2, acceptance of more CO2 in the maternal blood. Likewise, if there is difference in the partial pressure of oxygen, okay, between the fetal blood and the maternal blood, there will be more unloading of oxygen from the maternal blood to the fetal side. Okay, so this hyperventilation causing respiratory alkalosis will help the maternal blood to bind more and more oxygen until it reaches the placenta. And finally, if there is change in the or difference in the partial pressure of CO2 from the between the fetal and the maternal blood, there will be more acceptance of CO2 from fetus to the maternal blood. Coming to gastrointestinal changes, we'll be talking about GIT secretion, GIT motility, gallbladder functions, liver functions, morning sickness, and glucose tolerance. So GIT secretions, there is hypochlorhydria due to decreased gastric secretion. GIT motility decreases under the influence of hormones, resulting in delayed gastric emptying. Gallbladder function, there's increase in the size and it empties its contents at a very slow rate. So there is hypochlorhydria, decrease in GIT motility, and disturbed gallbladder function. Liver functions are also altered. We have already discussed that fibrinogen increases and albumin decreases. There is reversal of albumin globulin ratio, and fibrinogen increase is promoting a hypercoagulable state. Then morning sickness mostly during the first trimester, that is anorexia, nausea, vomiting, which correlates with the rise in the levels of human chorionic gonadotropin and progesterone, and the resulting relaxation of the smooth muscle of stomach. So all these factors are ultimately causing vomiting and morning sickness. Glucose tolerance. Okay, so we all know there is decrease in the threshold of glucose. Normally the glucose doesn't appear in the urine, but there is decrease in the threshold for glucose and more of glomerular filtration rate, more and more glucose is being filtered. Okay, so there is more and more appearance of glucose. It might show a picture of diabetes also. We'll be discussing it in detail in the next slide. Coming to metabolic changes, so we'll be discussing BMR, protein metabolism, carbohydrate metabolism, fat metabolism, and mineral metabolism. BMR increases by 15% during the later half of pregnancy. When the diet is balanced and adequate, there will be positive nitrogen balance. The protein metabolism will be well maintained if the diet is adequate. Carbohydrate metabolism, we know that blood glucose level increases due to rapid absorption from the gut. There is more and more absorption of glucose. Glycosuria appears due to increase in GFR and decrease in the renal threshold. There is decrease in the renal threshold for glucose. Hepatic glycogen decreases. There might be ketosis due to anorexia and vomiting. Then there is hyperplasia of beta cells of islets of Langerhans producing more and more of insulin. Okay. Fat metabolism. So almost 3 to 4 kgs of fat is deposited, leading to increase in the plasma concentration of cholesterol, phospholipids, and triglycerides. Mineral metabolism. We all know that calcium and phosphorus is very, very important for the development of the bones of the fetus. So the mother tries to retain more and more of calcium and phosphorus. There's decreased excretion of these two elements and more retention. Also, iron plays an important role. So there is increase in the demand of iron, more and more absorption of iron. Coming to endocrine system changes. So all the hormones relating to anterior pituitary, posterior pituitary, thyroid, parathyroid, adrenal cortex, and pancreas undergo changes. All these hormones undergo changes. In the diagram, you can see throughout the pregnancy, there is increase in the level of estrogen and progesterone, while HCG is increasing in the initial stages, later on it decreases. Then there is also presence of human placental lactogen throughout the pregnancy. It starts late, but it continues throughout the pregnancy. So all the hormones are showing changes during the period of pregnancy. We know that prolactin from anterior pituitary increases under the influence of estrogen. Then adrenocorticotropic hormone also increases. FSH and LH are suppressed. So follicle stimulating hormone and luteinizing hormone are suppressed because of the increased levels of estrogen and progesterone throughout the pregnancy. Thyroid stimulating hormone also rises. Posterior pituitary hormones, that is oxytocin, is suppressed during pregnancy, but it plays a very important role at the time of labor. Can anyone tell me what is the role of oxytocin? Two main functions of oxytocin at the time of labor.
Uterine contraction.
Correct. First is uterine contraction. Immediately after labor,
The stopping of blood to prevent PPH.
Okay.
Lactation.
Okay. Correct. Next
Breastfeeding.
most important is lactation. So it helps in the lactation or feeding of the fetus. More and more contraction of the myoepithelial cells of the mammary glands. Antidiuretic hormone also increases. Hormone of posterior pituitary. Again, this hormone is causing more and more retention of sodium and water. Size and secretory activity of thyroid also increases during pregnancy. Coming to parathyroid. Parathyroid hormone, we know that it helps in the absorption of calcium and decreases its excretion. So it is maintaining the normal levels or meeting the normal demands during pregnancy. Calcium and phosphorus are two important elements. So parathyroid hormone is controlling the levels of calcium and phosphorus. Adrenal cortex, there is increase in the glucocorticoids causing deposition of fat, and there is appearance of stria because of this glucocorticoids. Aldosterone increases, again leading to increase in the sodium and water retention. Mineralocorticoids also increase. So all these corticoid hormones or steroid hormones are causing increase in the retention of sodium and water. Pancreas. So we have just discussed about human placental lactogen, which stimulates the maternal lipolysis and fatty acid metabolism. As a result, this converts the blood glucose for use by the fetus. So there is more and more lipolysis, utilization of fatty acids. It can also decrease the maternal tissue sensitivity to insulin, resulting in gestational diabetes. So insulin resistance mostly is observed during the second trimester. Okay, we already know that there is appearance of glucose in the urine, but the tissue sensitivity for insulin, no matter there is increase in the release of or synthesis of insulin by the beta cells of Langerhans during the pregnancy, but the sensitivity of the tissues to this insulin decreases during the second trimester. So it might show a picture of gestational diabetes, which is very common these days. Coming to changes in the skin, so because of the release of different hormones, there occurs hyperpigmentation, mostly on the face, areola, nipple, and midline of abdomen, which is also called as linea alba. And stria gravidarum, there are linear scars on the lower abdomen due to stretching of the skin. Psychological changes, so there is craving for particular food items, there's alteration of behavior, mood, and emotion, but true psychosis is obviously very rare. To conclude the slide, okay, if you want to just take a look at the picture of what changes are occurring in the different system, you can always come to the slide. Okay, so different systems undergoing changes, that is nervous system, immune system, mammary gland, liver, digestive tract, then bone, okay, skeletal muscle, cardiovascular system, very important, hematological system, the spleen, renal system, and pancreas. So to conclude, if anyone can just, whatever changes they remember, if they can just name them. Any important things which you could conclude from this lecture, whatever changes are occurring. So Varna,
Yes, ma'am.
yeah, any changes you want to recollect or conclude? Any system changes?
I'll repeat like that.
Yeah, anything you could conclude or you could learn from this lecture, whatever changes you could conclude.
Actually, the maternal body has an adaptation to meet the demands, to fulfill the
Right.
demands of the baby. So there are
Yeah.
changes in almost all the system, including the neurological system,
Correct.
like anterior pituitary hormone, the endocrine system, which will increase the hormones,
Yeah.
except
So if we talk
FSH,
about the changes in the genital organs, we know that there is increase in the size of uterus,
increase in the
the
size of
uterine
the
increase.
uterus,
Yeah. The length is
the cervical
increasing.
changes,
Correct. The fallopian tubes, they are shifted upwards. There's
increase,
increase in the blood supply, right?
yes,
Cardiovascular changes, the heart rate is increasing, cardiac output is increasing, stroke volume is increasing,
limits
systolic blood
increasing,
pressure is not showing much changes, but there is vasodilation leading to decrease in the diastolic blood pressure, right?
yes, and the axis
Hematological
deviation.
left axis deviation is observed in pregnancy because of the shift of the apex bit laterally towards the left, right? Increase in heart rate. And then we've already talked about hematological changes, that is, there's decrease in the plasma protein, right?
So
Hemodilution,
the relative
physiological,
decrease in RBCs,
right? Relative decrease in the RBC as compared to the
clotting
plasma volume.
increase with the clotting factors,
Clotting factors
neutrophils
increase,
increased,
right? There's slight decrease
platelets,
in the platelets, right? Hypercoagulable state is observed, which is very
yes,
helpful during the labor to
yeah,
control the blood loss, right? Then there is urinary system changes, increase in the renal blood flow, urine frequency increases, more and more formation of urine, glucose intolerance, appearance of glucose and proteins in the urine. Okay. Respiratory changes, transverse diameter increases, right?
yes,
Respiratory alkalosis because of the presence of hyperventilation, which helps in the exchange of CO2 and O2 in the placenta because of the difference in the partial pressures of CO2 and O2. Okay, so placenta is almost acting as lungs for the fetus for the exchange of gases. Yeah,
yes,
metabolic changes we have already discussed. Just right. Hormonal changes, more and more formation of glucocorticoids and mineralocorticoids help in the retention of sodium and water. So increase in the plasma volume. Okay, more of the levels of estrogen, progesterone, which suppress the FSH and LH. So there is no more ovulation and no more follicular development. Okay. Any other doubt you want to ask? Vinod, you there?
Yes, ma'am, I'm there.
Yeah. So, any of the doubts? Could you understand the lecture?
Yes, ma'am.
Okay. Any of the doubts you want to ask?
No, ma'am.
Okay. So, I'll end the lecture then.
Yes, ma'am.
Okay. So, Anna, very nice contribution, Vinod. The rest, I think they must be having some problems they couldn't attend. But yeah, we have recorded the lecture, so you can always get back to this whenever you want. If you want the PPTs, let me know. Okay. Thank you for attending it. Yeah.
So we'll have more lectures on physiology, ma'am.
Yeah, there's one more lecture regarding immunity. So I'll be taking it. Okay.
And will you
Akanksha, you're
please
there?
take something for fetal physiology also, ma'am?
You want fetal circulation or anything?
Yes, yes.
Okay, fine
Ma'am,
then. If
why,
you
why is there an increased chance of gallstones during pregnancy? The residual volume of the gallbladder is more. Is it because of decreased motility of the GI tract?
yeah,
Or
I just shared one of the statement. Right.
ma'am.
So there is slow emptying. Okay, slow emptying from gallbladder. So more and more stasis leads to the increase in the formation of stone. Right. That's why it's very common in pregnancy. Yeah. So Anna, you were saying something?
Yes, ma'am. Something for fetal physiology or fetal
Sure.
circulation.
Any of the topics you want me to take, you can just put it on the group so that I'll be prepared with that and we can continue or take the lecture regardingly. Right?
Okay, ma'am. Okay.
Yeah, sure. Fetal circulation is one of the topics you want, right? And
Yeah,
immunology.
acid-base balance and fetal physiology.
Yeah, sure. So we can cover acid-base balance plus fetal circulation and uh, what you
Immunology.
wanted? Immunology, right? So that
Immunology.
though immunology is fixed, I'm going to take that. We'll add fetal circulation and acid-base balance. Okay.
Yes, ma'am.
I hope I
Yes.
could, portray my lecture to you and clear
Yes,
some of the
ma'am.
ideas so that, yeah, sure. If you have any queries, anything you don't understand, please let me know. I'll clear the doubts. I'll be most happy, okay, to do that.
Yes, ma'am.
Yeah, sure. So I'll end the lecture then.
Yes, ma'am.
Yeah. Thank you.
Thank you, ma'am.
Thank you, ma'am.